I'm going to be talking about cardiovascular disease and how it is related to dental and dental hygiene treatment. We know that there is an oral systemic connection. Chronic infections such as periodontitis are risk factors for coronary vascular disease and stroke. The bacteria that are found in the oral cavity in bacterial plaque have been identified in arteriomatous plaques, which are in the arteries in the heart. There's a clear link between periodontal inflammation and cardiovascular disease. Dental hygienists are in a great position to inform patients of the link and the risk factors and educate them to help them improve their oral hygiene care at home and make more frequent appointments to lower those risk factors. First, let's talk about the anatomical structure of the heart itself. We have the pericardium, which is the membrane enclosing the heart, which consists of the outer fibrous layer and inner double layer of the serous membrane. We have the myocardium, which is the middle thickest layer of the heart composed of the cardiac muscle. And we have the endocardium, that is the thin, smooth membrane that lines inside the chambers of the heart, and it forms the surface of the valves. The valves themselves allow blood to flow in a one-way direction through the heart to the blood vessels and into the peripheral circulation. Congenital abnormalities and heart defects affect the anatomical structure of the heart. Anomalies of the heart result from irregular development in the first 9 weeks in utero. So remember, the fetal heart is complete by week 9. Acquired anomalies are arteriosclerosis and hypertension or high blood pressure. There's infectious agents and immunological mechanisms that are acquired by the patient that cause heart problems. If we talk about congenital heart defects for a minute, the fetal heart is completed by 9 weeks in utero. So week 9, the heart is completed. Early diagnosis of any heart issues is necessary. About 25 to 50% of infants with congenital heart defects require treatment in the first year of life, usually a surgical correction. We know that there are some hereditary or genetic conditions such as Down syndrome where congenital abnormalities occur frequently. So we look for those when we have those cases present themselves. And environmental, most of our environmental agents or exposure from the mother to environmental agents within weeks 5 to 8 in utero can cause some congenital anomalies, abnormalities to the heart as it's forming. These can be from viral infections from the mother, such as rubella or cytomegalovirus, or from drugs that the mother is taking for other conditions, like thalidomide. Thalidomide is used to treat some cancers and skin conditions. It was used to treat leprosy in the past, and that can cause malformation of the fetus and the limbs. This slide shows a list of the most common congenital defects. So ventricular septal defect is a hole within the left and between the left and right ventricle. The blood can be exchanged through that wall that typically divides the right and left ventricle. It's a whole small defect. It can close. That's the most common defect. Severity depends on size. Some just automatically close, others need surgery. The second most common is the patent ductus arteriosus. A passageway is open between the two great arteries of the heart, so between the aorta and the pulmonary artery. Normally the opening closes during the first few weeks after birth. That's the second most common. Then there's atrial septal defects, so defect between the atriums of the heart, or transposition of the great vessels, which is the vessels are kind of going backwards. An infant that was experiencing these congenital defects would fatigue very easily, have trouble breathing, or have to, have labored breathing, maybe even fainting, blue lips and nail beds. They would be growing very poorly. They might have a chest, like a caved in chest or chest deformity, heart murmur, or congestive heart failure. Other cyanotic defects include tetralogy of Fallot, which is multiple defects persistent truncus arteriosus, tricuspid atresia, pulmonary atresia, total pulmonary venous connection, and hypoplastic left heart syndrome, where the left side of the heart is not working properly. The American Heart Association guidelines show that the cardiac conditions that are associated with the highest risk of adverse outcome from bacterial endocarditis should have a premedication or prophylaxis, antibiotic prophylaxis. So if a patient has prosthetic cardiac valves, so heart valves, if they have a history of previous infective endocarditis, and if they have certain congenital heart disease defects, so unrepaired shunts or conduits, completely repaired congenital heart defects that have prosthetic material. A lot of these, even if they don't need pre-med long-term, they need pre-med for the first 6 months that they, while they're healing and while the heart is trying to integrate the repairs. Repaired cardio heart disease with residual defects at the site or adjacent to the site of a prosthetic device, or cardiac transplant recipients. Except for those conditions that were listed on the previous slide, the antibiotic prophylaxis is no longer recommended for any other form of cardio heart disease or congenital heart disease. There used to be a big list of cardiac conditions that would need pre-med, heart murmur, mitral valve prolapse, and all of those have come off the list. And prophylaxis is usually recommended because endothelialization, or the integration of a prosthetic material, occurs within the first 6 months after the procedure is done. So like I said, some of the conditions might not even need it long term, but they will need it for the first 6 months. Which of the following does not require antibiotic premedication? Our congenital heart murmur, that is one that used to be on the list that is now off the list. How long should a repaired congenital heart defect be premedicated for dental treatment? 6 months. Education is the key. So patients who have congenital heart defects, who have any cardiovascular conditions really, need to come in for regular maintenance appointments, and they need a high level of home care and home oral health care when they have these conditions. Because a bacteremia is when we introduce bacteria into the patient's blood supply. If we are cleaning their teeth, of course we're going to go beneath the gum line, and we could introduce a bacteremia with dental procedures. But what if they're flossing and causing bleeding? What if they're brushing and causing bleeding? Some of the things that they do at home could also cause a bacteremia. So we need to educate them on how important it is to keep their oral hygiene good at home, on their own when they're not coming in for their appointments, and how the bacteremia and the oral systemic connection is related. Antibiotic premedication for the patient is not 100% fail-safe. We put them on antibiotics to protect them and give them that big super dose to take care of the large bacteremia, or the large surge of bacteria that is introduced to their system, but it's not always going to be taken care of with the premedication. Some of the acquired defects is rheumatic heart disease. This is a complication of rheumatic fever 2 to 3 weeks after the beta hemolytic group A strep infection. It's thought to be an immune disorder because the body is kind of attacking itself. A high percentage of patients who have had rheumatic heart fever have permanent valve damage, have rheumatic heart disease because of the rheumatic fever. 90% of rheumatic heart disease patients are between 5 and 15 years old. A high number have valve damage and are susceptible to endocarditis, but rheumatic heart disease is no longer on the pre-med list. Rheumatic heart disease, usually the onset appeared 2 to 3 weeks after beta hemolytic group A strep infection. This immune disorder was caused by the body's sensitivity to antigens of that strep bacteria. But like I said, it's no longer on the pre-med list, but we do need to be aware and make sure that we are talking to those patients about good oral hygiene so that they do not have a bacteremia that's introduced even by themselves at home that causes a problem. Mitral valve prolapse is the valve between the chambers of the heart is damaged. It does not close well. The three parts come together and it doesn't close well, and there's a backflow or regurgitation of the blood. It prolapses back into the atrium during the systole phase of the blood pressure, and there is a risk of endocarditis. This, again, is no longer requiring pre-med. The valve can't close correctly, and it can the blood can sit around that valve and regurgitate. So bacteria can stick to that valve because it's allowed to sit there longer than it's supposed to. Which of the following is an acquired heart defect? Congenital heart disease is congenital born. Atrial septal defect, ventricular septal defect are both holes between those atrium or ventricles in the heart. So it's rheumatic heart disease. Which type of organism is most commonly involved in rheumatic heart damage? Ooh, the wrong way. Beta hemolytic strep. During bacteremia, why does valve damage cause a risk for endocarditis? The valve is rough and the blood stagnates in that area, and it irritates that valve. So both 1 and 2. Infective endocarditis is caused by bacteria. Heart valves or the endocardium are affected. Transient bacteremia is created during invasive treatment. So during scaling, we introduce a bacteremia into we introduce a bacteremia due to our scaling, and it can be very serious. Masses of bacteria and blood clots on the heart valves can cause the heart to fail unless the infection is controlled. Almost any bacteria species can cause infective bacterial endocarditis, but it's usually a strep, specifically the alpha hemolytic strep, and staph bacteria can also cause infective endocarditis. Cardiac defects, prosthetic heart valves, a history of endocarditis, and IV drug abuse can be risk factors for endocarditis. If we know somebody has had a bacterial infective endocarditis, we try to avoid them having that happen again by using premedications. It could be a self-induced bacteremia. Like I said, they can introduce bacteria into their own system. So infection would enter at an area where there's a denture sore spot, a denser ulcer, a periodontal or gingival infection, or upon instrumentation. The bacteremia is initiated. It implants, it attaches to the damaged heart valve or prosthetic valve. Inflammation is in the area. The valve function is diminished. Symptoms usually occur within 2 weeks, and the patient would have a fever, loss of appetite, weight loss, weakness, heart murmurs. It requires premedication, or it requires hospitalization and IV antibiotics. Usually it's diagnosed by what the patient is telling the physician for symptoms, an echocardiogram, CBC, and blood cultures. They always has a risk of future infective endocarditis, congestive heart failure, or cerebrovascular disease or stroke. For premedication, we want to follow the American Heart Association guideline and be sure that the correct timing dosage is happening before we treat the patient. We want to document the medication that they're taking for premedication, the dose, and the timing. So premedication regimen for an adult is 2 grams of oral amoxicillin an hour before the appointment. So 4 500 milligram tablets. Child dosage is based on weight, and the doctor would figure out the milligrams based on body weight. But for the adult dosage, you want to make sure that if they have a 10 o'clock appointment, you ask them when they took the antibiotic, and they say, oh, I took it an hour ago. Patient took antibiotic, amoxicillin, at 9 a.m. for 10 a.m. appointment. How many tablets did they take? Because a lot of people will not take the required amount. They might be on an antibiotic for something else and they think that's good enough, or they might think that 4 is what's prescribed, but why don't they take 2 and then they can take 2 for the next appointment? And that's not enough coverage, because we're looking to get a super dose in there to be right on top of any bacteria that is introduced to the system, any bacteremia that's introduced to the system, to be able to control that and not have it go to the heart to cause the problems. So patient education for biofilm removal and having them do well with home care is very important. Using rinse to reduce the bacterial count is very important. Pre-procedurally, we have them do that in the clinic so that when we are in there with instruments and we are scaling, that even if we do and we are going to introduce bacteria to the system, it's a lower amount introduced to the system. Hypertension is a silent killer. A lot of people don't know that they have high blood pressure. How many people have been in the clinic, and I've told you guys this before, is how many people have found out that they have high blood pressure when they've sat in our dental chair and we've taken it. I remember when I was a student, there was a 22-year-old girl that came in, or female, that came into the dental clinic, and her blood pressure was very high. She had no idea and probably wouldn't have known for years that she had high blood pressure. We made her go and get a medical consult, blood pressure consult, and she had to go see her physician, and she got put on high blood pressure medication at 22 years old. Hypertension is the primary condition in 95% of the cases, and it's a secondary condition in 5% of cases. So it's second to other underlying medical conditions. It's a side effect sometimes of oral contraceptives, kidney disease, diabetes, or even some medications like decongestant medications can cause the blood pressure to rise. Which of the following is not a risk for primary hypertension? Renal disease, that is for secondary hypertension. Salt, obesity, and race, with African American males unfortunately being at a higher risk for primary hypertension. Remember, there's predisposing factors for primary hypertension: tobacco, hereditary, weight, race, higher for African Americans, diet, having a lot of salt in the diet, a lot of sodium in the diet. Men before age 45, women after age 45. Age, older you get, the more likely you are to have hypertension. Environment and stress are also risk factors or predisposing factors for hypertension. What is the end or cutoff for hypertension in the dental hygiene clinic? 159/99. Hypertension is elevated blood pressure, high blood pressure. Most common primary diagnosis in the US, 60 million Americans affected, and 70% are unaware that they have high blood pressure. This is the new guidelines that came out in 2017. This is the American Heart Association classification of blood pressure. And if we take a look at this new chart, normal is less than 120 and less than 80. So less than 120/80. Elevated is in that 120 to 129 and still less than 80 for the diastolic pressure. There is a lot of people that are above this. If we look at these two numbers for normal and just slightly elevated, these are pretty low numbers. Stage 1 hypertension is now 130 through 139 systolic, 80 through 89 diastolic. Stage 2 hypertension is 140 or higher, or 90 or higher. A lot of people fall under these hypertension now that were considered normal, even though they were above the 120/80. A hypertensive crisis is now greater than 180 and greater than 120. We want to take blood pressures on a regular basis to find out where our patients fall within this chart and to be able to guide them a little bit on getting medical consultations or blood pressure consultations to keep their blood pressure under control long term. Here's the stage 1 hypertension. We want to advise a healthier lifestyle and refer to the doctor. These patients are often put on low doses of antihypertensive or blood pressure medications. Stage 2 is over 140, over 90, over 140 for systolic, over 90 for diastolic. And we want to make sure that their organs are not being damaged by that increased blood pressure. So we want to recheck and make sure that we in fact did get a number over 140 over 90. We want to refer them for a blood pressure consultation or medical consultation to their physician. At this point, we would have no additional treatment, but it would be at the discretion of the supervising dentist. As we know, our guidelines are based on the old blood pressure, and that goes up to 159 over 99. But we have to take into consideration other comorbidities that that patient may have, and the fact that dental treatment makes you more anxious and raises the blood pressure anyway. So is some of it superficially elevated? Probably for a lot of people. Over 180 for the systolic number and over 120 for the diastolic is a referral to the physician. Low blood pressure can be a problem. Low blood pressure can be normal, which is the 120 over 80 maximum. And then if you sit a patient up, their blood pressure can suddenly drop off and they can feel faint. They can have orthostatic hypotension based on them being laid back in the chair for a number of hours or even a short time. But you know, our appointments go for sometimes a couple hours and the patient is laying back for that long. And that is, as soon as we sit them up, they have that drop in blood pressure as all the blood rushes back to their body. Systolic range of elevated blood pressure, 120 over 129, so it is lower than it used to be. Diastolic elevated blood pressure, 80. 80 is the start of the diastolic elevated blood pressure. Common cause of orthostatic hypotension. They can be on blood pressure medications or different medications that cause that, and the quick change in position, so all of the above. Lifestyle changes to decrease hypertension. Diet control and weight control, so eating lower sodium products, lower fat, lower cholesterol products, and controlling the diet and the weight. A third of our patients who have high blood pressure have no symptoms. 2/3 can have headaches, dizziness, some visual disturbances, weaknesses, tingling of hands and feet, ringing in the ears from time to time as their blood pressure's up. Long-standing severe elevated blood pressure can affect the brain, eyes, heart, and kidney. We want to make sure we make good referrals for our patient that can help them get their blood pressure under control so that we don't have any long-term effects on the organs. There can be mental confusion, stupor, even into coma and convulsions for long-standing high blood pressure, blurring of vision, loss of sight, patient having a hard time breathing, and ultimately having chest pains because of the severe elevated blood pressure. If a patient has a major sequela, it can lead to an enlarged heart, lead to cardiac failure. Their heart is trying to pump and trying to operate under that higher pressure, and it can lead to cardiovascular failure, can lead to strokes, can lead to heart attacks, can lead to kidney disease. Malignant hypertension occurs in 5% of hypertensive patients. Blood pressure rises rapidly, and a lot of times it'll go over the 200 over 100 blood pressure range. And we need to activate EMS at that point because there is definitely a risk for stroke for that patient. Hypertensive heart disease, there's an increased load on the heart. When the heart attempts to compensate for that higher pressure and maintain the same output, has its muscles stretched to the max, and the heart enlarges. The left ventricle enlarges first, then the whole heart enlarges, and without any treatment, the severity increases, and the left ventricular chamber in congestive heart failure fails. So the heart is just trying to pump, getting bigger, getting larger, muscles are stretched, it's trying to do the same output with less efficiency, more pressure. Heart damage can be due to, with ischemic heart disease or heart attack, there can be heart damage due to no blood flow to the muscle. Coronary artery disease, the arteries get blocked, thrombosis happens, blood clot happens, the arteries get blocked. They can be blocked by plaque that's on the artery walls or by a blood clot. And heart damage is a result of the lack of blood flow to the heart muscle. The demand or the need for the oxygen of the heart muscle is greater than what can be supplied, and there can be damage to the heart. Arteriosclerosis is where arthromas deposit on the wall of the blood vessel. So fatty deposits, fatty plaque deposits, cholesterol deposits. Somebody with higher cholesterol can have deposits that are forming inside the lumen, the round part of the artery. It can close that. It can make it smaller, 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 and then it can close. Calcifies, and if it calcifies and it's a really small opening, there can be a blood clot or a bacteremia that goes through that really small opening that actually blocks it or severely reduces the blood flow even more. If somebody has a low-grade infection, periodontal pathogens, and perio shares a lot of the same risk factors, increased lipids, tobacco use, diabetes, obesity, low physical activity. All of these are making the perfect storm for a blocked artery or a blocked valve or infection relating and causing and contributing to this ischemic heart disease or the heart stopping, heart failing. Manifestations of ischemic heart disease are chest pains, myocardial infarction, which is a heart attack, and then ultimately congestive heart failure, where the heart fails to continue to make that output. It enlarges, it has fluid around it, and it cannot pump and produce the cardiac output that the body needs for operating efficiently, which is not part of the emergency response to an angina attack in the dental chair, is to place them in a supine position. We want to place them in a semi-supine position. We are going to provide oxygen. We are going to reassure them that everything's going to be okay. We are going to give them nitroglycerin if they are having chest pains. Angina is chest pain. So if they're having chest pain attack in the dental chair, one of our first things we're going to do after providing oxygen and reassuring them is to give them nitroglycerin. Often patients who have angina attacks carry nitroglycerin with them. When should EMS be activated during an angina attack? When the patient does not respond to the second dose of nitroglycerin. They're going to take a dose. If they don't respond, they're going to take another dose. If they still do not respond, then EMS will be called. Usually within 3 minutes, they will have a vasodilating effect and the chest pain should subside. The nitroglycerin is going to be placed sublingually, so underneath the tongue. If a nitroglycerin container is opened and a patient actually takes a tablet of nitroglycerin, that packaging can only stay open for 6 months. The potency is lost after 6 months. So they'd want to get a new prescription. What is likely happening when the patient does not respond to the nitroglycerin vasodilator? Vasodilating means that the blood vessels are opened more. Instead of being tight and constricted, they're allowed to open. If they're not responding to that vasodilator, it's likely they're having a heart attack. not just angina pain, but myocardial infarction, which is a heart attack. Classic symptoms are chest pains, jaw pains, nausea. A feeling of overheating is not a classic symptom. Women kind of have a foreboding feeling like something is going on. They don't have the same pains as men. Whenever I get a woman in the chair who has had a heart attack, I always ask for, like, how did you know? And I want to know their symptoms, because their symptoms are often very different from what a male would experience. Patients should wait for 6 months after a heart attack before an elective dental procedure. And this is congestive heart failure. This is kind of what I was talking about before. The heart's unable to meet the demands that it needs to for output to the body. Fluids build up in the organs in the heart. It can be because of heart valve damage. It can be because of heart failure due to the muscle abnormality or due to ischemic properties, where parts of the heart are not operating properly because of a reduced or stopped blood flow to some of the blood vessels. Precipitating causes can be if they've had pulmonary embolisms, so blood clots that have broken off and gone through and are blocking any arteries or any blood vessels within the heart. If they've had a hypertensive crisis, if they've had different arrhythmias where the heart is not pumping the same, it's arrhythmia, the beating of the heart is not an even beat. Symptoms for congestive heart failure, we're talking about cardiovascular disease, but specifically congestive heart failure. Symptoms are based on the side of the heart that's affected. Could be both sides, but general symptoms of congestive heart failure include weakness, fatigue, fear, because they feel like they can't breathe and they're very weak and they're very fatigued, and anxiety. Treatment can be drug therapy, limitation of activity, having them sit, rest, and controlling their diet. Dental implications for congestive heart failure are we need to ask good questions in their medical history. We need to watch them for pain or cardiac distress signs. We don't want to place them all the way back. Semi-supine would be better. We want to use stress reduction protocols. We want to have oxygen available and kind of have it in the back of our minds that if a medical emergency started to occur, if they got an angina attack, if they started feeling faint, we would be able to have it on our mind to activate EMS if necessary. Treatments for cardiovascular disease range, all over the place based on the severity. So some is just counseling, sending them to their medical doctors, doing some lifestyle changes and having things controlled with medications. Those are very non-invasive. Other are surgical treatments that include dilation of the arteries in the heart, so angioplasty, where they kind of go and make some changes to the arteries themselves. Stretching with balloons to widen the lumen, going in like kind of rotor-rooting to remove plaques from the artery walls are more invasive surgical treatments. Coronary bypass is where they actually bypass an artery that is blocked or mostly blocked. There can be patients with significant obstructions. Sometimes they will use veins from the legs to put them in the heart and bypass the heart veins or arteries that are, I shouldn't say veins because veins go away from the heart, but the arteries that are blocked. There can be cardiac pacemakers placed in the heart. The natural pacemaker is in the SA node in the right atrium, and it regulates the pumping of the ventricles. But cardiac diseases can make that rhythm unreliable, and it can interrupt that rhythm based on myocardial infarctions, heart attacks, or arrhythmias, or blockages. So sometimes a cardiac pacemaker is placed to regulate and take the place of the naturally occurring SA node. So stimulation from the cardiac pacemaker can be on a single chamber of the heart or on more than one chamber. It has leads that go to the heart, and it's usually affects the endocardium, can go to the pericardium. Electrodes are connected to a power source. So typically on their upper left chest, they will have a plastic or metal encased pulse generator with a lithium battery. It's implanted under the skin, usually upper abdomen, and it has a rate responsive pacing that it does for that patient. And demand pacing is used most commonly. The cardiac physician will regulate that based on the patient needs. Interferences for the pacemaker are electromagnetic. So there's shielding in most of the pacemakers models that have been implanted since 2010. Things that we use in the dental environment could interfere with the pacemaker. There are equipment, used to be our ultrasonic couldn't be used. Our sterilizing, our ultrasonic sterilizer, our instrument shaker, our appliance cleaning station could not be used because the vibration from those could affect the heart pacemaker. If a patient is having a malfunctioning pacemaker, they would have difficulty breathing, dizziness, a change in their pulse, swelling because their heart is not pumping and beating like it should, so fluid would be allowed to build up in the legs and ankles. They could have chest pain and hiccuping. Prolonged hiccuping can be a symptom of malfunction. So if somebody has the hiccups and you know that they have a pacemaker, a referral to their physician to have that looked at is a good idea. Appointment guidelines for pacemaker patients, but for cardiac patients in general, we always want to look at stress reduction protocols. Anything we can do to reduce their stress while they're in the chair and make it a better, less taxing on their cardiac system is better. We want to ask thorough medical history questions. We want to know the type of pacemaker, how long they've had it, where it is, any underlying conditions or any comorbidities with the cardiac pacemaker. We want to get informed consent and make sure that we know if they've had problems in the past. We know if they've had to have any emergency medical treatment. The first 6 months after placement could require a pre-med, so we want to know dates of when it happened. We don't want the chair all the way back in the supine position, semi-supine, and we don't want to put any pressure over the site. Which of the following may be harmful to the pacemaker? The magno-restrictive ultrasonic scaler, which is our Cavitron. The piezo is still fine to use. Which emergency procedure should be done first in the pacemaker emergency? We're going to activate EMS. We want them there quick. And luckily Brownson is right next door, so they have a fast response. What is not a sign of emergency in a pacemaker patient? Relaxation of muscles. They're going to get lightheaded, they're going to have some trouble breathing, and they're going to be dizzy. How long might a pacemaker patient need antibiotic premedication? 6 months, just like everything else. And then our anticoagulation. We're going to have a lot of patients who are on heparin, Coumadin, warfarin for blood thinning. We want their physicians want the blood thinner to be able to move through their system and not clot and not block valves or arteries. So preventing an embolus or thrombus formation is controlled with anticoagulation therapy. And sometimes patients are on this for the rest of their life. Sometimes it's after surgery for a certain amount of time. My dad just had colon cancer surgery and they wanted him on anticoagulant for 1 month after surgery. Some, it's the rest of their life. So most common are heparin, Coumadin, warfarin. It's not safe to suspend the anticoagulation medication for dental procedures. We want to know their prothrombin time, their clotting time, their coagulation time. Normal would be between 11 and 13 seconds. Their INR, normal is 1 to 2. INR for a patient who is on anticoagulants should not be more than 3.5. If it's more than 3.5, that would mean that they're not coagulating in a timely fashion, and we would need to get a consultation. We don't want to go in and do some scaling, which is going to cause bleeding, and not have a patient be able to stop bleeding. So cause a medical emergency from our dental cleaning. If the patient is still kind of working on the dosage and they're new to medication, or they don't know their prothrombin or their INR time, if their prothrombin time is greater than 27.5, or if their INR is greater than 3.5, we would want them to have a consultation before elective dental treatment. Point of care is POC. So if you see that acronym POC, it's point of care. There is a new coverage by insurance that is allowing patient to test their clotting time at home, and it allows for them testing closer to their appointment. There are new drugs out there, new anticoagulants. Pradaxa is one that was recently approved, Eliquis, and Xarelto. Xarelto, it had the hopes that it could be taken once a day versus twice a day that the Pradaxa and the Eliquis need to be taken. So these are some names of some other less common anticoagulants that you may see. And those are kind of starting to leak into the clinic onto patient medication lists. If you are planning for a patient who is on an anticoagulant and you're planning dental hygiene treatment, you want to begin in the least involved area. Usually we tell you to begin in the worst area. Here you want to begin in the least involved area and see how they're going to respond, and see and make sure that you can get the bleeding under control. You want to educate the patient and have them make some improvements. You guys have seen patients where there's lots of inflammation because there's lots of plaque. If we begin in the least involved area and then we can help them with plaque control, then they come back, and even if they have calculus and even if they have scaling and root planing that we need to do, we can at least have the tissue in better shape and maybe reduce the bleeding that they would have. We want to remove the accretions, so the plaque and the calculus, with emphasis on having them maintain a high level of home care. We want to make sure that we're not doing any tissue trauma that's going to cause any additional bleeding on top of the bleeding that they're going to have, or that's going to be increased because of being on the anticoagulant therapy. We want to make sure that bleeding has stopped before dismissal. We can use pressure. Hygienists cannot suture, but if a area needed to be sutured because a tooth was extracted, say that day, or if periodontal dressing needed to be placed in an area, that could certainly be done and needs to be done before the patient leaves the office. Post-op instructions for someone on anticoagulant therapy is going to include to avoid vigorous toothbrushing for several hours, even until the next day. They may need ice packs, soft, cool diet, which will take blood away from the area instead of hotter foods bringing blood to the area, and kind of decrease or keep their level of activity on a more moderate level. PT for patient not on anticoagulant therapy is 11 seconds. Pradaxa, Eliquis, Xarelto, and Plavix are all new drugs, but the Pradaxa is the one that just was approved by the FDA, or most recently was approved by the FDA. INR of an individual not on anticoagulant is 1. We want it not to be over 3.5 for dental hygiene treatment. The letters POC are point of care. In Michigan, we can apply, as hygienists, a periodontal dressing. We can apply pressure. We can control the bleeding, but we cannot place sutures. We want to have a patient decrease activity. We want to have them use ice packs and soft, cool food, but no toothbrushing for 48 hours is not a recommendation. Cardiac surgery. We want to educate the patient to prevent any endocarditis. Improved home care. We are the prevention specialists, so we want to really work on prevention. We want to make sure that patients know that there's sometimes a 6-month wait after a heart attack or stroke. and possibly pre-med. So if in doubt, have a consultation with the cardiac physician. Take a look at some of the drugs that a patient might be on if they have to have any heart transplants. Cyclosporin and nifedipine may be prescribed for heart patients, and they both cause gingival enlargements. Stress protocol. Patients may have to have sedation the evening before, the morning of appointment. They may have to have intra-operative or intra-procedure sedation. We want to make sure they have effective pain control so they're not releasing endogenous epinephrine from within. We will use morning appointments. We don't want to keep them there for lengthy appointments. Shorter appointments are going to be within the patient's tolerance level. Hot, humid weather can affect a patient. So we may want to avoid appointments during hot, humid weather. Make sure that the patient has post-operative prescriptions for pain as needed. Giving a patient a call the next day if they're an ASA 3 or 4, or if they have had a traumatic procedure, been under sedation, is great. All right, thank you for your attention.